Okay, so the studies I found show that hospital readmissions are potentially preventable in almost 40% of the cases, and heart failure is the most common reason for readmission. And the readmissions can reflect fragmented care, can be extremely cost ineffective for the institution, and can be a hardship on the patient. And then in the Lutheran mission statement, in the handbook, it states that the hospital is dedicated to providing services spanning the continuum of need for diagnosis, treatment, and rehabilitation, and for health improvement. So this is a tool to document on the continuum of care. We have a diagnosis of heart failure, we are assessing it, we're treating it, we're making sure that the treatment's working. And then it's serving people with compassion regardless of their race, gender, age, religious beliefs, or economic status. Obviously, this is helping us to serve with compassion. Even if we don't feel like we have the time, this is a tool that we're supposed to use to help improve outcomes for our patients. And then up in the how, I'm going to go over this because it's still related to the mission statement, is continually exploring, developing, and implementing new concepts and reevaluating existing programs in the interest of improvised services and optimized use of resources. So this is a resource that's been provided to us that not many people are using, and this is our way of trying to explore it, develop it further, and help get it instituted as a used resource. Emphasizing high standards of ethics and professional performance on the part of staff members, and cooperating with other health and social service providers to foster continuity of service and optimal utilization of community resources. So this helps us to have professional performance because we are a heart failure unit, and this is helping us. It's a tool that we're supposed to use to make sure that we're doing what we need to do on a professional level. And it's also helping us cooperate with other health and social services, because if we need a chest x-ray, we need to communicate that with the right healthcare team. If we need an AICD, we also need to talk to, some social services. We need to talk to the people that need to address the issue with the patient.
All right, so I'm going to talk to you about the golden question, how? Okay, so the simple fact is it needs to be done. We can't get out of it. Our job is to make it more convenient and easier for the staff, not to eliminate it. At one point I was told the original pathways used to be a packet, front and back, very in-depth. It is now very condensed, okay? So it's not going to leave, it's not going to go away, and at some point it is going to become mandatory. All shifts need to participate, including the charge nurse for these heart failure pathways, okay? As we seen up here, a common barrier, involvement of all shifts. This is how we're going to do it. Because it is more efficient for certain shifts to complete certain sections of the pathway due to time results, lab, and daily weights, we have devised a plan where certain shifts will complete certain sections of the pathways. Ironically, there are 3 shifts and 3 major sections of the pathways. The first section will be completed by first shift. Easy to remember. Second section will be completed by the third shift, and the third section will be completed by the second shift. Okay, this is due to morning labs. Second shift, they're not going to get the first section, INOs, that's going to be first shift. That's in the very morning. You can calculate that daily INO, their daily weights. The second section, those labs are drawn at an ungodly hour, okay? So that needs to be third shift. It helps out all these different shifts. When they come on, they can see this up-to-date information being transferred at shift. So bedside report, that's why it's important. That's why we're doing these. It keeps the whole staff involved. And really, as Samantha mentioned, these don't take long, especially if you only have to do one section, only a few minutes of your time. It's very crucial. By involving all the staff, you're not pulling the whole wagon by yourself. You're involving everyone, and it's a team effort. And really, like we said, some shifts want to do it all. They do, but they can't, because at certain shifts, certain times of the day, these results aren't back, okay? So everyone is responsible, however, for the ancillary goals. Everyone is responsible for educating the patients on the brochures. So we need to keep that in mind. The second part of our implementation is the use of colored folders. These aren't the big bulky binders that you had in the past. These are in the chart, and just like your discharge folder, these are going to be a bright color, easily identifiable, one of the barriers we identified here. And easily accessible, not forgettable. You're going to know where they're at. They're going to be in the chart. However, this is how charge nurse will be involved. They will place the pathway in the colored folder in the binder for the chart. Okay, so that's where they're going to be at, guys. We need to really get this solidified in our heads. However, let me make a key note. Angie's agreed upon it. It's got the okay of our unit. She thinks it's going to be a great idea. I think it will be too. However, we still have to get the okay from higher up, Angie's boss. So they're not implemented at the current time, but they will be very shortly. And it's crucial to note that once they do, please, guys, let's start completing them today. But as far as now, they're located in the central charge nursing station in the pull-out drawer, okay, where they've always been. Okay, I'm going to let Samantha take over from this point.
I'm just going to put one quick note on this too. Another way that the charge nurse is going to be involved in the heart failure pathways is upon discharge, they will file them into a specific location for documentation of them being completed.
Yep, so they won't be thrown out and they won't continue to be in the chart. Also, it's key to note too, I was just reminded of this today, if you want to get heart failure certified, this is one of those crucial tools you need to access and complete in order to show that you are being educated and using a heart failure tool, a labeled and official heart failure tool. You need to complete this if you want to get heart failure certified. Go ahead, sorry.
Okay. And then I'm just going to talk a little bit about the Outlook. So some nurses already use these and some of them don't. We've found that typically the veteran nurses, some of them don't really use them because they feel like they already do that without the use of the pathways, and some of the newer ones don't use them because they have no idea where to start with these pathways. We think that some of the veteran nurses, especially the ones who already do the pathways, this can help implement it with the newer nurses because seeing you fill them out is going to encourage them to use this, see it as a tool, and continue to look at it for any kind of trends or things that they might learn from it. It's a guide for improving rapport and including the patient. Take this into the patient's room with you when you're giving a report. Use it as a tool to teach the patient about why they should monitor their intake and monitor their output. Let them know that their daily weights are extremely important when they go home and they should monitor them every single day. It's being led to be mandatory assurance for the ACT, so if we don't start improving on this, it's going to be mandatory. It's going to be mandated that we all fill them out. Why not start now? And finally, if the heart failure pathways have become condensed, sectioned off for each shift to do, less for each nurse individually to complete, and known to improve patient involvement and outcomes, what's stopping us from using them? What could we possibly say against these to prevent us from using them as a tool to improve our patient care? And some other things that I found that are extremely important, some labs or some studies that I found say that BMP values and some of the other labs as well correlate with better outcomes and has been advocated to have an important role to gauge the success of treatment and to also determine the prognosis of overall disease process. So if you see a high BMP on your patient that's about to be discharged today, maybe you should talk to that doctor about possibly keeping them for another day. And that's something that you'll see better if you have it here, where you can see, oh, it was 800 on this day and now it's 1,000. So now instead of getting better, we're getting worse. And then the Centers for Medicare and Medicaid Services and the Joint Commission have made reducing heart failure readmissions a core measure. It has been found that these readmissions are also linked to fragmentation of care among the continuum and are hardships for the patients, which is something that we already talked about. But if this improves patient care, if implementing this can help us improve the lives of our patients, why not implement them so that we can reduce their readmission rate? And then finally, there's a quick fact down here. An average day of stay at a for-profit hospital is $1,843. So if you multiply that across a readmission of 5 days, or, they just got discharged, but we could have kept them for 1 day instead of having them readmitted for 5, we just saved the patient and our own hospital, because the readmission falls back on us, a lot of money.
All right, thank you guys. Thanks for watching. We really want to get the compliance up. Please, Angie, please the staff, get your heart failure certifications. And overall, like she just said, let's start now. It's eventually going to be led to mandatory if not done. After watching this, we're going to leave some post-evaluation teaching little worksheets. Please complete these. I'm going to leave them up at charge desk. And thank you for watching.